Hello, we meet again. I'm Miss Kinan and I'm going to talk today about musculoskeletal assessment on children. Today's objectives are to know what are the musculoskeletal assessment on children and what are the nursing care for children with musculoskeletal problems. When we're talking about musculoskeletal assessment on children, we have to understand that the bones in infant, they're not completely ossified. So the bone are not yet firm and they will be then ossified later in teen years. And the ligament sometimes also still have the maternal hormones, and sometimes the gait of toddler are still immature, and then it's less mature compared to the gait of an adult. And sometimes also we can see that the ankles and the feet of the toddler still have like a different form because it's not yet fully formed. And we have to remember that the bone child is easily to break, and we just need to be more cautious about how to assess skeletal on children. So we will see more when we are conducting assessment on children. We need to make sure that we know the patient's name and their age, and then we also need to build a trusting relationship because we're dealing with kids. Sometimes it's just difficult. We have to sort of like gain the trust of the patient and gain the trust of their parents, and then we also need to adjust our assessment according to the growth and development stage of the patients or the child. And sometimes communication will be difficult, so we have to really make sure we do a play interaction with the children. And we also make sure that after our assessment or even after our care, the patient will have a peaceful and pleasant experience. We don't want the patient to have traumatic care, so at our best we will try to make the patient have a traumatic care. And we have to understand that its stage and the children's age are just different. So as a nurse, we have to consider and pay attention to the physical development, the cognitive development, language development, psychosocial development, moral development, and also discipline development. For example, when we are doing assessment, we ask the children to walk to the door and then walk back to the nurse, and then we will see whether the children will be able to obey and do what we want them to do. So that's what we need to consider when we are talking about musculoskeletal assessment on children. These are the picture that I want to show you because in a focused assessment for musculoskeletal, obviously we are going to concentrate on the development of the bones and the muscles of the children. And we have to observe the spine as the biggest bone. We see if the bone, the spine have a normal curvature, and whether the baby or the child have scoliosis or lordosis. We also assess the mobility of the spine, so we ask the patient to bend their back. We see if they can follow through the order and then bend their spine nicely. And then we try to see the extremities, the leg, the hands, and then the toes and the fingers. We see if there are polydactyls or is there any syndactyls on the children. Polydactyls means more than normal fingers. Syndactyl means a fuse of bones on the fingers. And we also see the form of the leg, whether it's a bow leg like this one, so it's like O type or O shape of feet on the baby, because the tibia just laterally open. And we have also what we said knock knee, so that the knee getting close and the legs are open. So this is, both conditions are actually what we expect to see in children, but both of them are not actually according to anatomical position, but we just have to notice that this is what we can see in children. Next one is about how we assess the gait or the walking style of the children. We will notice that the children will have the pigeon-toed style of walking, or sometimes we can see also the plantar or grasp reflex, and actually it should be a flexion on toes as a normal walking style for the child. We also assess the joint. We see if the range of movement is proper on each joint. We observe is there any uh, dislocations on baby's hip, and we also see if there is immobility or just basically hyperflexibility on the joint. We also palpate the joint where probably because there is a problem of the joint, we can feel the heat, and there's also probably tenderness and also swelling on the joint if there is a problem on the joint. And we also assess the muscle, we assess the tone and the strength and even the muscle strength. And we can do this by assess the extremity strengths in children. We ask them to assess the strength of the arm. We ask the child to raise the hand, and as a nurse we put pressure from above and we try to push down, so we can see if the children has the strength to push up the pressure that we gave to the hands. And we also do check the hand strength, so we ask the children to shake our hands and ask it to like really give a grasp with maximum strength. We check on both hands of the children. And we also do the leg strength, so we ask the children to sit on a table or on a chair with the foot dangling, and then we ask them to raise their feet, and then we put pressure on the feet and to see if they're having enough strength to just push through the pressure and raise their leg, and we check it on both feet. So this is what we need to notice as the baby is still developed, so we have to see whether the baby will be able to hold a certain position. We have to see that the baby have a round spine. When it's 1 month, the baby cannot hold it. As the baby grow, we will be able to see the baby will be able to sit by itself. As the baby is learning to sit by itself, we need to see whether the baby sit in a proper position, alignment, or this is like tilt to the right. And then once it's growing bigger, we can see that the baby is sitting like down properly. And then we also will see that the baby will begin to learn how to stand. We just observe whether it's a normal way of standing, the feet, and once they begin to walk, we can see that this is a normal to see in the baby, that's a tiptoeing walking, and the baby will learn how to crawl. We can also see that, and the baby will learn to move with their hands and positions the feet in a certain position that he's able to handle. Next, on the musculoskeletal assessment on children, we will then assess in a healthy child the general appearance. We observe the well-being of the children, observe if the child has irritability or if the child is composed and able to follow instruction. We ask the child to walk, to sit, and to climb to see if there are any problems muscularly or if the limbs are not functioning properly. And then we assess the neck, we assess the range of motion, if the head is able to, if the neck is able to support the head. We ask the baby to, or the child to, bend the head, tilting it. We see if there are any problem. And we see the shoulder and the upper extremities. We observe the range of motion again, should be no decrease in the movement. And then we observe the wrist and finger, asked to do the movement of the wrist, open and close the fingers, the palm. We should see there's no decrease in movement. And we again focus on the spine. We see the curvature of the spine, whether it's in a good position, scoliosis not present, lordosis not present, and is in the right alignment. And we also assess the hip, supposed to have a tolerable range of motion with no extra skin fold and no hernia or other condition that might be seen on the area of the hips. Then we also observe the lower extremities. We have to see that the limbs, the feet, they are in a symmetrical position with no club foot, and we observe the ROM, whether it's a complete range of movement or is there any inability to move. Then we observe the knee. There should be no swelling on joints, should be no pain. We observe the movement of the knee. We ask them to sing the song Head, Shoulder, Knee and Toes, and we will be able to see how the child will be cooperated with us in doing the movement on the song. And also we ask the ankle to raise the heel and then walking, tiptoeing, to just make sure that the ankle is like holding the body, and then also move the ankle to see there is no sprain and there's no swelling on the joint. Then the last, we will observe the feet. We will see that there is no foot drop, and also that the toes, they are in a normal anatomical position. So this is what we need to assess with the maneuver of ortolani. So we bend the hip and then we make sure that it's going to the acetabulum, like this hip bone is inside the acetabulum, and we bend and we click, like we open it. We do adduction and we will need to observe the sound of click. If we can palpate that, hear that, it means there's a problem on it, but then we should not expect to hear anything. And then we also do a Barlow maneuver. It's kind of like similar, but we try to do a dislocations of the unstable hip, but then we will feel also that it will be slipping out of the acetabulum, but it's still there. It's with the Barlow maneuver. Then we also do the Alice sign. So position the patient in the supine, bend the knee, and you will see the similarity of the height of both knee or legs, and this is what we call Alice sign. And we also do this abduction of the hips, and we see if the hip is able to be abducted 90 degree or only like 50 degree, there will be no difficulties. And then we ask the patient to stand on one feet, and we will see if there is change on the height of the hip, if there are any pelvis drop, or is it just a normal one. Then we ask the patients to do this position, lying on the stomach, prone, and we ask the feet to be up like this. Then we will see this is like the normal alignment in the middle, and then when we see like tibial extorsion, the plantar will go outwards, and when there is like internal torsion, the plantar will be inside. So this one is the bony, like the O figure, and this is like the knee knock. So the knee are close together. So this is not a normal alignment, but this one is the normal alignment that we want to see in their legs. So we need to remember that when we're assessing musculoskeletal, somehow it's related to the neural system. And we just also assess the tendon reflexes for the patient. We assess the bicep, tricep, brachioradialis, quadricep, and Achilles. So this is what we do. We assess the tricep by putting the hammer over here, the flex hammer, and then we assess the bicep over here, so the hands will move upward, and then we assess the patellar or knee jerk. When we hit the patellar, we will see that the legs going upward, and we also assess the Achilles reflex. When we hit the Achilles on the back, the plantar will go up. So this is what we need to do to assess the musculoskeletal on children. Next, we are going to talk about what to expect when we are dealing with child with musculoskeletal problem. So the first step in nursing process is the assessment. So what we will assess. So we ask about the current history. Is there any problem that they are noticing on their child, whether it's pain, it's weird movement, it's deformity, is any swelling on the joint, if the child is limping, not walking properly, if there is a history of recent injury, for example, falling down from somewhere or having like sprain or strain, so we assess that. Then we also assess the past medical history. When the child is still a baby, how is the pregnancy? Is there any like a really problem from the beginning? Like for example, the baby was born in a breech position. There's the tendency of the baby to still be in the position like that until the baby is bigger. And we also assess is there any health challenges that's going on with the child, like really history of previous surgery, hospitalization, fractures, or even like hyperactivity or attention deficit disorder. So we talk about that too. And we ask if the child have a childhood illness, for example, polio, tuberculosis, or even conditions that really affect the spine. And we check the immunization status of the baby, when is the polio and HIV, influenza shot, as well as the tetanus shot. And also we see if the baby is having medication allergies or any other allergies that is really interfere with the musculoskeletal system. And then we also ask about the current medicine, if the child is taking like extra calcium pills or any other medicine that might be related to musculoskeletal problem. And we also assess their nutrition. We see if the child is having obsessive appetite, or is it just a normal appetite? Is there any calcium containing food or any vitamins that they take to make sure that the bone are growing properly? And then we also assess the family medical history, if there is like a congenital disease or any other things that related to skeletal and neurological system. Then we assess also has the environment, the social and environmental history, whether the child needs to climb the bed every single day to sleep, or the child just sleep on the floor. That's why the child tend to choose just crawling, not to walking, because it's like just on the floor. So those type of things are the things that we consider when we are assessing the musculoskeletal system of the child, as well as we assess their growth and development. So we make sure that we assess baby for the capability that the baby could do. For example, we assess the toddler, and we ask the toddler to close their eyes, raise one leg, and then we ask them to run into a shape. And we also ask like school child to probably close their eyes and try to walk or walk backwards. So it's sort of like type of things that we need to be aware of. And then we also assess if there are any activities that will cause the musculoskeletal to have a problem. For example, if the children used to just study while bending or on the bed studying, so their back will have the tendency to have a lower doses. So those type of things are things that we assess on the children when they have musculoskeletal problem. The next step is to make our assessment very comprehensive. We are going to collaborate to do a diagnostic test to assess the musculoskeletal problem. We can do a complete blood count, we can do CRP checking to see infection, calcium and phosphorus level to see the renal and skeletal disease, and rheumatoid factor to see if there are any autoimmune response, and then erythrocyte sedimentation rate to see how is the inflammatory process, what trigger it, and then we also do the blood culture and sensitivity. We make sure that if there is any septic condition or even infection, we will know how far and where it is. And we also can perform in collaboration with the specific pediatrician or even specific orthopedics how to do bone biopsy if we do see that there are swellings and problems on the bone that really needs a deeper study to make sure what is that on the bone tissue. And we can do an assess on fluid aspiration from joint. For example, in elderly, their knee will have a swollen position, and the doctor, orthopedic doctor, will try to aspirate the fluid and to see what is the cause of the swollen. And we also do arthrography to really study about what is going on the joint. And we also do bone scan to make sure is there any cancer or metastasis condition that's coming to the bone. And we also do a computed tomography or CT scan to see the bone from different angles. And we also do magnetic resonance imaging or MRI to really have a thoroughly understanding about the structure, the mechanism, the metabolic and circulatory abnormality that might be found on the bone and muscles. And after that, maybe the doctor also will just simply order like a simple x-ray and even just using an ultrasound to just assess the certain location that they want to assess, and it's like instant, easy, on the spot. So normally we will collaborate with pediatrician to order this to just make sure that we know what they are doing and how to like really explain to the patient and the family about what is going on, what we are expecting to see. And the doctor can simply start from a simple procedures of ultrasound, then to x-ray, and then to, if they cannot see, then to CT scan or MRI. If the situations got worse, then we do need a bone scan and arthrography or even like aspirations from the joint and even bone biopsy to just make sure what is going on with the musculoskeletal system of the children. So, after doing a thoroughly assessment on the child, having diagnostic support, we coming to diagnose in nursing. So, nursing diagnosis that we can have is the acute pain related to the musculoskeletal condition, and we can also see that can be impaired physical mobility. They can also be a risk for peripheral neurovascular dysfunction because of musculoskeletal disorder. And we can also have an impaired skin because tractions, casts, or braces or other external fixator that is being used. And we can also have a constipation on the patients because decreased activity or mobility can decrease the motility of the intestine. So patient would have the tendency to have constipation, and sometimes also impaired in urinary elimination because patient cannot move because of the cause, and they have just basically difficulty to pee, and it causes another problem in the patient. And we can also consider if the patient have delayed growth in developmental stage related probably to lack of stimulation or just because the mother and the father, they're just working, and the child just stay behind with the nanny, and the nanny just used to like hold the baby the whole day without leaving the baby to play, to crawl, to learn how to walk. So that's also can be a problem. Or if the baby or the child is bigger, with the presence of the cast or using of the crutches, the baby or the patient will have what we call like low self-esteem. So that's what we need to be aware of for the nursing diagnosis when we are taking care of the children with musculoskeletal problems. Now, there are a few interventions that as a nurse we need to know. The first one is if it's only swelling, sprain or strain, we can apply cold and heat. We can also have like braces or splints to just make sure that the baby is having their bone positioned in a correct anatomical positions until their conditions getting better. Or some patient will might need a serial of manipulation, so certain activity, range of movement that we need to do for a certain period of time to just make sure that the range of motion is going on accordingly to the needs of the child. And sometimes we also found that the patient has cast, just to make sure, as I mentioned in the beginning, that the bone of the children, they are still not obsessified, so they're not really firm bone. They tend to crack, and we just have to put it into an anatomical position for the bone to really heal itself and ossified. And some patients also will have traction, external traction or internal traction. Means like if internal traction, it's the pen that you installed when the bone is broken. External traction means like there's no pen, it's just like pulling the bone to be in a proper position for a certain time. I mentioned about external traction, external fixation also like can be a cast, that we just make sure that this is the maintained position until the bone is held. Some of the patient will need a surgical intervention to put fixation internally and externally, and some of the patient will then walk with ambulatory devices, so we need to make sure that we teach the patient how to walk with it and to make sure that they are not injured themselves on the process. And some of the patients also, they will have what we call the prosthetic devices when they are doing amputation, so we just make sure that they are having a good self-esteem and they're doing well with the prosthesis that they're using. Another intervention that we can do is to promote the intake of food that will increase the bone strength. So with eating calcium, phosphorus, and vitamin A and vitamin D, we hope that the patient, the children, will have good bone strength. Another thing is the condition. So there are a few conditions that we need to understand. Sometimes the alteration is just because it is what it is from congenital defect, and we know what we call metatarsus adductus. So it's like this, like the bone, it's just bent somehow on the metatarsal, and we know what we have clubfoot, and also we will see what we call dysplasia of the hip. So the hip just basically get out as a tabulum, and then the feet, it's just like not in a proper position. So we need to be aware that there are certain conditions that we need to know on our patients with musculoskeletal problems. Sometimes it's a really like defect from the limb because of congenital condition, and we can also have osteogenesis imperfecta, that the bone is just forming but it's not perfect. And we can also see that patient have muscular dystrophy, and then we can also see that patient have torsion deformity because of femoral underversion or even just tibial torsion, and LCPD or leg calf pertus disease, and we have slip capital femoral epiphysis, and also we can have osteoarthritis and also scoliosis. So these are the types that will alter the musculoskeletal status of the patient. Some infection and inflammatory disorder also might happen on the musculoskeletal system. For example, if there is any osteomyelitis, infections of the bone and the muscle, and we can have a septic arthritis that there the joint is having infection, and sometimes you also have juvenile arthritis when the knee just being overused for certain reason. And we can also have what the systemic lupus erythematosus condition is an immune system sickness. And another thing is because of trauma that happened to musculoskeletal. For example, because of sports injury, there are fractures, overuse injuries, and sometimes also sprain and strains, and also problem with dislocations. So these are the problem that we need to consider when handling children with musculoskeletal problems. So this condition can lead to a problem in the musculoskeletal. These are the books that I use for these materials. I hope you learned something. Thank you.